She's a loving wife and mother, also a former Georgia State trooper. But little did she know, in the fall of 1999, that God would have her to be chosen to conquer. Here's Colette Jenkins and Chosen to Conquer.
Welcome back to Chosen to Conquer. And I'm the host, Colette Jenkins. And listen, I am so excited today. I get to introduce to you my new friend. Actually, he has become my favorite doctor, which is after a couple of weeks of dealing with some of the issues that I've dealt with several months, and actually probably about a year. I got a chance to meet my new gynecologist. And I will share with you a little bit about how this relationship has grown to where we're going to bring the information to you today. So let me introduce you without further ado to my new gynecologist, and probably yours too, Dr. Brandon Seagle. Welcome, Dr. Brandon.
Well, thank you, Ms. Jenkins. I appreciate you inviting me onto the show. And, you know, I'm kind of curious. You said you like to wing it, so I'm curious what we're going to talk about. Let's do it.
Let's do it. Well, listen, I think, look, the relationship has been established, and that's the thing. I really believe that what we do here with Chosen to Conquer is really just conversation. And I like to reach our people that are listening and then sometimes watching to really feel like what I'm talking about, they could possibly see themselves, but then hear something that can maybe affect them or their family and friends. So how I met you, I called you Dr. Brandon, but you're Dr. Seagle.
I'm good with whatever I'm called. It's fine with me.
Just don't call you Colette. Listen, that's what I always joke people about. Don't call me Colette, but you can call me Colette.
Don't call you Colette, is that the joke?
Don't call me Colette, but you can call me Colette.
I get it.
But listen, Dr. Seagle, how did this come to be? I've been a patient at the Veranda here in Albany for some years to get my women's needs. I always come in for my annual checkups, and then, of course, the actual thing for my mammograms and things of that nature. But my doctor, I believe, is coming up to time to retire. So I was speaking with one of the nurses that I've made friendships with, and I was telling her, since the pandemic, I've not come back to get my mammogram. I didn't go in the year 2020, which was last year, to get my mammogram. And I was kind of concerned. And she said, well, listen, now that your physician is going to retire, I said, well, listen, I'd rather just go ahead and begin a new relationship with one of the new physicians. And she says, well, listen, you've got to meet Dr. Brandon Seagle. Everyone is talking about him and how thorough he is. In fact, he has an amazing bedside manner.
That's nice to hear.
Isn't that amazing?
Mm-hmm.
Well, her name was Miss Walker. She's a nurse.
Mm-hmm.
Over in the she was there. I met her during my mammogram. Mm-hmm. And so she mentioned you, and I said, well, listen, I trust you. All those things you just said, that checks out, and I want to just go ahead and give them a call. So I called and scheduled my checkup with you, and that just really began the process.
I'm glad you did.
I am
I'm
too.
glad you did.
Yeah. So what the main thing was, like I said, I was coming in just to get started with my mammogram, and then we came in together. And when you first walked in the room, I remember thinking, first, number one, he's young. Not to say that that's necessary, but what was so necessary was your personality. I said, we can make it. We can make it. And I got to tell you this. When you first told me we had to do a physical exam, and you said I had to do a pelvic exam, I said, wow, I'm just meeting him. I said, oh my God, why do I have to do this when I'm just now meeting you? You haven't even bought me drinks. That's exactly what I told the nurse, and they thought it was funny. But the thing is, you were very proper. All of the nurses, the two, I believe you had two. One that you were training, I believe, was an intern, mm-hmm. I believe, mm-hmm. at that time. But we got everything on the road. You went ahead and scheduled some of the main things that I told you about, the things that were concerning me, the pain, the heavy bleeding that I'd been experiencing. You asked how long it had been happening, and the ball got rolling. And mm-hmm. so my question is this. is to mention this because of the pandemic last year. Have you noticed that a lot of patients put off coming in for their regular scheduled checkups?
They have locally and nationally. It's actually been a big deal. Early in COVID pandemic, there were some numbers came out, and it's probably higher at this point, but the numbers were about 26% of medical practices in the country closed and 13% were permanent. And that was back in the summer last year. So a lot of practices actually went under in terms of small practices, rural practices, community practices. Of course, big hospital systems and big large groups may have weathered the storm better, but a lot of places had trouble literally just keeping their doors open. A lot of the smaller medical practices in the country, and a lot of that has to do with that it's expensive to provide medical care. And it's if there's a big dip in the patient volumes coming to the office, it really hurts the practices. And I'm just bringing that up just to say that's evidence of the fact that a lot of people didn't come in for the care they were supposed to get. I mean, I had people who needed surgery and were planning to have surgery back in March of last year who we're just doing now because they're finally not scared. And and so there's been some people who didn't change their lives at all. They just acted like COVID didn't exist. And then there's been some people who still are probably not coming in and getting taken care of. I've got actually a patient who needs to be followed for cancer, who I'm always asking, we haven't seen her in a long time. I tell my nurse, Jennifer, I say, Jennifer, give her a call and, make sure she's all right. And I see her son actually where he works. And I ask him, how's your mama doing? Does she have this? She have that? Any problems? No. He said, we're keeping her locked up because of the COVID. And I'm like, okay, if she has any of these problems now, y'all better call me.
Get to you. Okay.
Yeah. So,
that's scary though.
Yeah, it is. So, she's been treated for her cancer.
Okay.
So,
Good.
Otherwise I really would be knocking on her door, but she's been treated for her cancer. But, there's just follow-up maintenance, the things you're supposed to do to get, checked on.
Okay.
And a lot of people aren't doing those things. And chronically, that's a problem in society. A lot of people don't take care of their health very well.
True.
And so it's just sort of been made worse, I think, by COVID. Now it's starting to rebound. It really is. A lot of people in the last several months, I think, are either they're just accepting that we live in a new world where there's a new risk and it's COVID, and just like many things are dangerous, there's a chance you could get this COVID and it could hurt you or kill you.
Correct.
And they're choosing to go on with their lives anyway. And I think there's a lot of that going around nationally and locally, and it's gotten to where everybody, or I feel like everybody, knows somebody who died of COVID.
Correct.
Or they know someone who directly know someone who knows someone. They either know someone who died from COVID, or they have a relative or a close friend whose relative or close friend died from COVID. It's gotten to that point that it's really touched everybody. And Albany was hit hard early.
It was.
Albany was hit hard early. So I think we're probably among, I always say there's places in the country that are still experiencing kind of the shock that we were getting over in April and May and June and learning to live with it. There's places in the country that are still experiencing that wave coming through, and it's new to them.
Initial wave.
Yeah, and we've had wave and wave and wave,
Correct.
And so I think we're getting used to life in the COVID world.
Okay.
And it's getting better, with vaccinations. I think to myself, thank God, I hope everybody gets this vaccination. There's so many anti-vaccination ideas out there.
Correct. Most
of them don't make any sense to me whatsoever, but if you're not going to do it for yourself, do it for your community. Get out there and get the vaccination.
Well, that sounds great. One thing I want to do is just stop at this point, because I didn't give you a chance to introduce yourself, to say a little bit about who you are. And I was excited to know that my new doctor was a native of this area. Mm-hmm. And so I just wanted you to tell us a little bit about where you're from and your medical experience in this area and where you've gone above to serve.
Okay. Well, my grandparents and parents are from Daugherty County and grew up in Daugherty County. My parents went to Daugherty County schools. And I was living, and my grandma lived in Daugherty County actually till she was, needed help.
Okay.
we grew up out actually near Radium Springs. I used to live near Radium Springs, very close to the school over there.
All right.
And that's where my grandma lived. And then when I was young, we moved to Atlanta, real temporarily, a suburb for like a year or two. And then we came back, and when we came back, we were living in what I call sort of South Lee County, which is right across the line from Albany.
Correct.
And I grew up there, so I grew up in a neighborhood called Glendale. A lot of people from Lee County, they know where Glendale is. It's behind the Publix. The Publix used to not be there. All that stuff wasn't there when I was growing up.
Exactly.
But I grew up there. I stayed there until I was 18, and I went to college at the University of Chicago, and then medical school at Stanford, and done a lot of training in different places. Went to University of Washington in Seattle and did an internship in general surgery. Then OBGYN residency with my wife. We couples matched to Danbury Hospital, which is a Yale-affiliated community program in Connecticut.
Oh, wow.
And then I went and did training in GYN oncology at Northwestern. And my wife, Dr. Ye, went and did urogynecology fellowship at Yale. And then, I came here in August of 2018. And Dr. Ye joined me here when she finished her fellowship in July of 2019. And so she's originally from Taiwan, and moved to Seattle area when she was in about 6th grade.
Wow.
And all her family's abroad or in California, so she was fine to come back to my hometown.
Was she?
Yeah,
Oh,
and
that's
she's used to
amazing.
moving around the country.
Sure.
So we came back. I feel weird. I was here 18 years. I left 16 years, and now I'm back.
Well, that is awesome, though.
A lot has changed, but a lot is exactly the same.
Don't have that look on your
the
face.
same. A lot is the same.
Exactly the same. That's the
I like it,
hometown
though.
stuff, though.
I
I
like
really
it.
do, too.
Yeah.
Well, I'm super excited about that. That's some of the things that I'm happy we get to talk about as well sometimes during my appointments. But I want to move forward back to where we were going when we talked about my appointment. You did help me check on some things I was concerned about. As I mentioned, my mammogram, so I was able to get that done. And you helped me really get a better understanding of maybe some of the things I was really concerned about, maybe not as concerned after all. But then when you told me, as I talked to you about, listen, I'm really tired of this heavy bleeding every month preparing for that day. And then here it is. I really have to pretty much schedule it and then just kind of stay home and then, go through the cramping and all of that process. And I will just never forget when you said to me, you don't have to live with that.
You don't. I like to joke that I have enjoyed 37 years without a period, and life is better without one.
It is better without a period, isn't it?
I can't imagine. I really can't imagine.
Oh, wow.
I mean, I take care of women all day. A lot of them have these problems, so I hear what it's like. But when I think about it myself, I think I must be the biggest wimp in the world. If I have like the slightest pain, I'm like, what is wrong? And I just cannot imagine if I knew, like on a calendar, it's coming, and it's going to bleed a lot, and it's going to hurt a lot, and it's going to interfere with what I want to do in my life. I can't imagine how tired of that I would get. And so when you came in and you had, issues with bleeding, and when other women come in and say something, I'm like, you don't have to put up with that anymore.
You don't have to put up with them anymore.
There's a lot of ways to deal with that.
It was so funny.
There's a lot of ways
What'd
to
you say?
deal with it.
Divorce it.
You don't have to deal with that anymore.
You don't have to deal with it anymore.
You don't have to deal with that anymore.
Wow.
There's a lot of ways to deal with that.
And so what did you tell me to do? What were my options?
Well, in general, options depend on what is the cause of the bleeding.
Exactly.
And what is really the anatomy of the uterus. Sometimes there's distinct causes that we can treat medically. Sometimes there's structural causes like fibroids, polyps, depending on where they are, how large they are, how many they are.
Okay.
Different people have different paths.
Okay.
But there's sort of 4 standard umbrella type of treatments. Okay. So one is medical management that suppresses ovulation. And so the most common example of that would be birth control pills.
Okay, exactly.
And birth control pills have estrogen and progestin. Think about estrogen waters the grass, progestin cuts the grass.
Awesome.
You can water the grass every day, but if you cut it every day, it stays low, aka bleeding. The endometrium doesn't get too thick, the bleeding doesn't get too heavy.
Okay.
So medications that have progestin in them in general lead to less bleeding. Now, as people get older, the risk and side effect profile of those medications goes up, and we don't tend to use them as often.
Okay.
And then the other thing is progestins locally in the uterus, aka a progestin secreting IUD. And so that's an option that some women have. Another option is endometrial ablation. A simple way to think about that is like microwaving the endometrium. So that's a reasonable option for some women. And then, of course, the definitive solution is hysterectomy. You know, if you remove the organ that bleeds, it won't bleed anymore.
It will not.
And it won't cramp anymore. So, you know, that's the definitive solution. So I tend to, you know, every woman who comes in with a bleeding problem, we try to figure out why are they having the bleeding problem.
Right.
And then what are reasonable options for treating their specific problem.
Okay.
And then we just, you know, my approach is I discuss here are the reasonable options, here are the pros and cons of each of those options, and what do you think would be good for you, or what would you like out of those things? What would you want to do? You know, and what questions do you have? So.
And I remember you giving me all of those options, and I believe one of the main things that you did say, let's start with first, taking a look. Let's do a screening and take a look at my uterus. And we did do that X-ray, or I believe it was ultrasound. Yep. We did that ultrasound, and we got that, came back in, and you told me exactly what it said, and you said, okay, looks like you'd be a good candidate for a hysterectomy. And let me tell you, I got to mention this because I know I'm 50 years old, and I remember when I looked at you and said, I won't be able to have another baby.
Yeah, I remember that conversation. That was kind of funny.
Why was it funny? And it was so funny because you looked stunned when I said that. And you said, well, I think you kind of said, well, you really shouldn't have a baby. And I said, why? And you pointed at this number and it said 50. I said, I'm 50. Yes, I'm 50. But Janet Jackson had a baby at 50. Do you remember that?
Was it her egg? I don't know. That's the question I'd ask.
That was the statement you made, too. But the funny thing is, I really wasn't interested or intending to have another baby. But it's something about when you know that this house that would carry the baby is no longer going to be present. It caused me to panic in a sense. But when you make that, of course, that statement, and of course, laughter is the best medicine for me, but you helped me really kind of put that to bed. So the decision was to go forward with the hysterectomy. The interesting thing was I went home, of course, and talked with my husband. I called all of my girlfriends and Dr. Seagle. I called them, and guess what they said?
What?
Oh, I had hysterectomy 5 years ago. Oh, I had a hysterectomy 10 years ago. I could not get one friend to say, I don't know about that. Everyone said that was the best decision I could have ever made. I was like, why didn't y'all tell me?
Yep.
But the interesting thing was, their answer was this: because you had MS, Colette, and we didn't think that would be something you'd want to think about.
Really?
And truthfully, I believe that's why I put up with it as long as I did. Number one, I didn't think it was something to complain about. I was already complaining about the other pains that I couldn't deal with, and I thought that was another one of those pains and issues that I just had to live with. And so thank God I said it to you, and your answer was so perfect and on time that I could hear it and believe you. And then further, my friends could back it up and give the stamp of approval that it was the best decision they ever made. I'm so happy that it was a decision that I felt guardedly. I made that with you and my husband. So we went forward. And so now, the thing about how were we going to do the hysterectomy? And so my question was, okay, so how do we do it? You began to explain. How are hysterectomies done? Well, first of all, is a hysterectomy? What is that?
Hysterectomy, just that specific word, literally means removing the uterus. And the uterus at the bottom has a cervix. Think about it like a cork on the bottle.
Okay.
And then there's the body of the uterus. And if you just say hysterectomy alone, most people assume these days you mean removing the body of the uterus and the cervix together.
Okay.
That is what we call a total hysterectomy, as opposed to a supracervical hysterectomy, which used to be a lot more common in the early days of laparoscopy, and that would be where you leave the cervix in the patient and you cut the body of the uterus off, because technically the cervix is a little harder to remove.
Really?
So in the early days of laparoscopy, a lot of people had supracervical hysterectomy, and that was because they were operated on at a time that was really in the learning curve of most gynecologists in the country, having to be self-taught, having to really to teach themselves laparoscopy. You have to think a lot of the gynecologists in the country trained and finished their training before video laparoscopy existed, you know. And so if you finished your training really before the early 2000s, you probably were little or none trained in advanced laparoscopic surgery.
And laparoscopic surgery is using
small instruments through small incisions. You know, instead of having a big incision on your belly side to side or up and down, you know, you can just make little 1 centimeter incisions or less and put all the instruments in and do the surgery.
Amazing.
Yeah.
Amazing.
Yeah.
And that amazed me as well. I had back in the 90s, late 90s, I'd had a tubal ligation, which was done laparoscopically.
Yeah.
And so I was familiar with that. So when you told me that, showed me the size of the incisions would be, I felt great about it. But then we went further, and I talked with my internist, Dr. Young, and he mentioned, you know, that there's no screening for ovary cancer or, you know, cancer of the ovaries. And he said, I think it'll be best if you just, since you're already at that age now, near, you know, menopause, just go ahead and get those ovaries removed as well. So when I mentioned that to you, your thought on that was what?
In your age group, so around 50s, it's really elective for most people. So women who are 65 and older, we really recommend them, advise them, if you're going to go through the trouble of having hysterectomy for any reason, just take the ovaries out.
Okay.
They're certainly not doing you any benefit. Women who are younger, in their 40s and certainly younger in their 30s and their 20s, we try not to remove the ovaries, right? We don't want to give people early surgical menopause.
Okay.
But women who are close to the age of natural menopause, we really talk about what are the risks, what are the benefits of leaving ovaries, and we'll compare that to sort of hormone replacement therapy.
Okay.
And then you get to make the choice. And there are some women who come in who have strong family histories of ovarian cancer, breast cancer. We say, you know, it's a really good idea. You probably should consider taking those ovaries out.
Okay.
There's other women who come in and have low-risk family histories and are adamant they want to keep their ovaries. We say, hey, if they look good, we're going to treat them like MC Hammer. Can't touch this. You're going to leave them right there. You know what I'm saying?
Love it. So you don't. I mean, but that's a good point. Well, with me, to consider, as I mentioned, I do have multiple sclerosis, and some of the risk factors, side effects possibly, based upon the treatments that I'm using right now currently for MS treatment, it does show that there could be potential risk of cancer. So that was one of the things I thought about as well when I made the decision to go forward with the ovary removal. But everything went great. But what the final thing I want to discuss was what was so shocking when you said, let's schedule the appointment and we're going to do this outpatient.
Oh, yeah, I like to tell people it's not your grandma's hysterectomy anymore. And, you know, it's really not. Somebody will pop up online and tell me I'm wrong, but my impression is when I came to Albany, I was the first one routinely letting their patients go home on the same day as having a minimally invasive hysterectomy, because the nurses in the hospital are like, what? Dr. Seagle, you're sending your patients home? I was like, yeah, of course, they're going to do fine. You know, where I train, we send 60 to 80% of people home same day after hysterectomy, even for cancer. So you can safely go home. There's things called enhanced recovery protocols now that are been well established but slowly adopted around the country, and we use those principles in how we treat you before, during, and after surgery so that the recovery is a lot easier. I tell people, I say, you're going to go home the same day. You're going to take pain pills, not IV meds. You're going to eat regular food, walk around. You can do everything you would normally do except two things. Nothing in the vagina until we know it's well healed, and no heavy lifting. That's it.
That was it.
That's it.
Oh my gosh. And I tell you, a little over 2 weeks ago, that became reality for me. And I cannot tell you just how amazed I was. The surgery, the process showed up that morning. And from the front door to that same exit door going home was nothing short of, and I say it sometimes, it was a party. It was a party. It was a party. Everyone, and my prayer, I said, God, you know your daughter. I get anxious and anxiety about a lot of things. This one, I don't want to be concerned about. And as they checked me in, and the nurses were phenomenal, and I say that again, but meeting some of the other doctors that were going to be assisting you in this hysterectomy, they really made me feel good. It felt like these were my classmates. And you guys ushered me on back and brought me back to my husband, of course, in it seems like a moment. But the surgery you mentioned was about an hour and a half. But I came home and I felt a little sore maybe. I knew I just had surgery, so I wasn't trying to take laps. But that first week, maybe the second day, I was questioning, did I really have surgery?
Wow.
Because I told my husband, I feel so much better. I feel better than I probably felt in years. And I just want to thank you. I truly thank you. And the doctors and nurses at that hospital at Phoebe, it made the difference in the world to me. And so I'm looking for people to get hysterectomies.
I'm glad you said Phoebe there, because I'm going to tell people, I really want people to watch your video on YouTube. I want the team at Phoebe to know how much they're appreciated and how doing the hysterectomies this way, everything that's been done in terms of pre-op, anesthesia team, post-op, surgical care there, that, patients really appreciate it.
Yes,
and it works.
Absolutely.
It works.
It really worked, and I'm so grateful and thankful that I had it done. And the fear completely is gone. And as I mentioned, I highly recommend you, Dr. Seagle.
Oh, thank you.
Oh, you bet. But I mean, just that process. If you're having those concerns, all, as Dr. Seagle mentioned, women, we all know every month this is coming. And if you're dealing with the extra bleeding or any type of extra pain or anything that's causing you the loss of your quality of life, consider there is an answer, and you do not have to suffer. And so if this is something that you may or may not be interested in, I recommend that you give Dr. Seagle a call at the veranda. And if the decision is made based upon your history or even your clinical matters, if it's time for you to make that decision to do it, do it. I know that you'll be better. I'm looking forward for the next 4 weeks. I'll be going back in 4 weeks to get that last exam, last exam, but that final post-op exam. But I know I will be so much better just simply because I made that decision to go ahead and have it done. Now, you did mention to me, I cannot do squats, I can't do planks, I can't do free weights, I can't do, what did you say? I can't do all that heavy stuff that I want to do right now?
Yeah, don't lift more than 20 pounds.
20 pounds.
Yeah.
So look, I won't be doing my weight training right now, guys. So I'm going to leave Miss Olympia to next year. But what I will be doing...
You're trying to get swole. You're going for Miss Olympia.
That would be
I want
great.
to see you a couple years and be like, Dr. Seagle.
Dr. Seagle did this to me. But listen, without Joe, I am so grateful. And I'm thankful to God for him using you to make the difference in my life. And so I will be looking forward to the next appointment. And one final question I have, will I still need a gynecologist now that I don't have a uterus and ovaries anymore?
That is a good question. There is, a much reduced risk of having, any type of disease that's really in the ballpark of gynecology because you don't have a cervix, you don't have a uterus, you don't have ovaries, right? So if you have a really good primary care doctor who's taking care of you, like an internist or family medicine doctor, you don't have any gynecology problems, and they do pelvic exams, you really don't have to. And they would tell you that you don't have to do a pelvic exam. That's actually what they would tell you. So that being said, OBGYNs do provide primary care for women. We pay, I think, a special attention to breast cancer screening, colon cancer screening, and certainly there are other things that come up with the skin around the vagina and vaginal issues as women age that other physicians are not attuned to even look at, ask about, recognize, treat, prevent. So I think
Dr.
there's
Seagle,
benefits.
what you're saying then, this new relationship established is not over. So
I
I will
think
still
so.
come back to see you.
I hope so.
Sounds great. Dr. Seagle, thank you so much for coming and sharing all of this wealth of information with me and our friends. And we hope to see you again next time.
Thank you.
We'll see you all next time.
You've been listening to Chosen to Conquer. Chosen to Conquer Incorporated is committed to empowering, educating, and assisting individuals with the devastating effects following the diagnosis. Listen to Chosen to Conquer every Saturday beginning at 4. Also, for more information on Chosen to Conquer, go to chosentoconquer.org. Listen to Chosen to Conquer every Saturday at 4 o'clock on WZBN, Praise 105.5 FM.